Buenas noches para todos, buenas noches a quienes se conectan desde América Latina en este tercer webinar, en esta tercera sesión del programa de NASPGHAN, visita a LASPGHAN. Esta noche tenemos a 3 invitados de la Sociedad Norteamericana de Gastroenterología, Patología y Nutrición Pediátrica, y una de ellas, una experta en esofagititis eosinofílica, que es el tema que precisamente vamos a tratar hoy. Vamos a comenzar por saludar precisamente a nuestra conferencista invitada. Se trata de la doctora Calies Menard-Katcher, quien se conecta con nosotros desde Colorado. Ella pertenece al staff de la Escuela de Medicina de la Universidad de Colorado y por supuesto también al Departamento de Gastroenterología, Patología y Nutrición Pediátrica del Hospital de Niños de Colorado, en donde no solo es profesora del Departamento de Pediatría, sino que también dirige el programa de investigación sobre enfermedad o enteropatía, gastroenteropatía eosinofílica. Así que es una experta en la materia y con ella vamos a discutir hoy un tema muy interesante como lo es esofagititis eosinofílica. Dr. Calies Menard, are you there? Good night. How are you?
I'm well, thank you. Thank you for having me.
Welcome. Thank you very much for participating with us in this program. Okay. We also welcome Dr. Benjamin Gold. How are you, Ben?
Good evening, buenas noches, and want to greetings to everybody again for this third and this wonderful series of NASPGHAN visits LASPGHAN. I'm really excited listening to or looking forward to listening to Dr. Menard-Katcher's presentation on eosinophilic esophagitis. I think you all are in for a treat this evening. And again, to my LASPGHAN brothers and sisters, we appreciate the collaboration, the partnership, and the relationships and bonds that are being formed through these programs. Again, thank you so very much.
Gracias, Ben, por tu adherencia al programa. Igualmente, Carlos, porque han estado con nosotros en lo que va del programa, acompañándonos presencialmente y virtualmente a la vez. Así que muchísimas gracias. José, ¿cómo estás? Buenas noches.
¿Qué tal? Muy buenas noches. Buenas noches a todos. Es un placer estar con ustedes aquí otra vez y la verdad es que unión de NASPGHAN y LASPGHAN en los seminarios ha sido bastante exitoso y tenemos expertos en el tema y ha sido un agasajo de programa y hoy con la doctora Calies, que es una experta en esofagititis eosinofílica. Así es que con gusto estar aquí.
Perfecto. Bueno, pues entonces ahora vamos directamente a la conferencia y nos vemos a la vuelta. Recuerden que pueden utilizar el chat como siempre para hacer sus preguntas. Lo pueden hacer en español, lo pueden hacer en inglés. En esta situación globalizada, de alguna forma nos comunicaremos. Así que vamos a escuchar ahora a continuación la conferencia de la doctora sobre esofagitis eosinofílica. Bienvenidos todos.
So thank you to Dr. Pierre and Dr. Gold and Dr. Garza for this invitation to speak with you today in this NASPGHAN Visits LASPGHAN series. Thank you to all of you for spending some of your evening with me. And I look forward to our time at the end for some questions and answers. I'm going to be speaking to you today about eosinophilic esophagitis, therapeutic options, and long-term prognosis. I have no disclosures. So the learning objectives for this evening will be for you at the end of this talk to know the long-term reasons we treat eosinophilic esophagitis, to be able to recall therapeutic strategies in EoE, and to recognize an upcoming role for biologics in the treatment of EoE. But first, let's start with a conceptual definition of EoE, specifically drawing attention to EoE being a chronic immune antigen-mediated disease of the esophagus, and one that requires both clinical symptoms and histologic findings. From caring for our patients with EoE, we know patients can present with varying symptoms, with younger children often presenting with vomiting, abdominal pain, or feeding difficulties, to our school age or older children describing dysphagia. Children more often tend to present with inflammatory features in endoscopy with white plaques, edema, and linear furrows, whereas older adolescents and adults more often will have esophageal rings and strictures identified on endoscopy. Duration of inflammation and/or age are currently seen as the dominant risk factors for the presence of fibrostenotic remodeling. As shown in this figure on the left, Schopfer and his team eloquently demonstrated that fibrotic features represented by the dark gray and black bars were more common in adult patients the longer symptoms were present before diagnosis. On the right, we have a predicted probability model by the North Carolina group that shows that the risk of fibrostenotic features on endoscopy increased with age. And indeed, 2/3 of adults with EoE will have fibrostenotic features at the time of diagnosis, as compared to really only 10 to 16% in our pediatric population. But what is fibrostenotic remodeling and what are its clinical implications? We can see evidence of fibrotic remodeling in the subepithelium. Here in an adult patient with EoE, we see the dense collagen as compared on the right as compared to the lace-like collagen in a normal esophagus on the left. And we see this in children as well. In these trichrome strains, you can see the delicate lacy pattern of the fibrous tissue in normal biopsies as compared to EoE patient, where it is dense and compact on the right. Now, I will be honest with you that I do not know the clinical implications of subepithelial fibrosis on biopsy with regards to long-term outcomes. However, esophageal remodeling does impact treatment response and patient outcomes. Here we see the esophageal rings and long segment narrowing seen on endoscopy and esophageal narrowing on fluoroscopy. But detecting esophageal remodeling, particularly in the pediatric age group, can be challenging. Here we have a relatively normal appearing esophagram, but when the child swallows a barium dissolvable tab, we see that it gets stuck, and it takes more than 5 minutes for this to dissolve and be able to pass. So one way that we have been evaluating esophageal remodeling in pediatric patient population is with the use of EndoFlip. This is a balloon catheter that is placed during endoscopy and measures intra-bag pressure and diameter at 1 centimeter intervals along the catheter. And from this, a measurement of distensibility can be made. We have shown that distensibility is decreased in children with eosinophilic esophagitis compared to controls, and that among children with EoE, distensibility is decreased in those with evidence of fibrotic remodeling, whether that be histologic with respect to lamina propria fibrosis, endoscopic features of fibrotic remodeling, or a history of stricture. EndoFlip may allow us to detect and monitor esophageal remodeling before it becomes apparent as it might in esophageal stricture. Here we have an example of 3 patients with eosinophilic esophagitis. On the left is a relatively normal EndoFlip for a patient with EoE in the sense that the esophageal diameter is 15 millimeters or more throughout the esophagus. In the middle, we see a more obvious stricture, and this luminal narrowing seen in the middle was likely identified on endoscopy. However, on the right is a more subtle narrowing, not detected on an endoscopy. But as you can see, the luminal diameter is well below 15 millimeters, and this patient may need more aggressive medical therapy or may benefit from a dilation. But back to this concept of fibrostenosis being a progression of disease. An alternate theory is that while duration of inflammation is certainly a large factor in this outcome, whether or not fibrostenotic EoE may represent a particular disease phenotype. To support that concept, the North Carolina group published on their experience found that adults with narrow caliber esophagus, defined as an esophageal lumen less than 10 millimeters, was resistant to treatment. Now, only 9% of their patient population was defined as having an extremely narrow caliber esophagus. These patients were older and had longer symptoms of duration, but they also were more refractory to steroid treatment with lower symptom, endoscopic, and histologic response. For example, 33% having histologic response compared to 63%. Also in this concept of whether different phenotypes may exist, what about our very young patients? So we know that some of our patients present very early in life. When the Cincinnati group recently published on these very early onset EoE patient population, borrowing a little bit from our IBD colleagues with very early onset IBD. And they defined this as EoE that was diagnosed in patients less than 12 months of age. And while they hypothesized that this patient population may have a more severe disease phenotype, they actually found that this group was more likely to attain histologic remission with diet than older children, and did not seem to go on to develop strictures. Supporting this concept that there may be distinct phenotypes that also impact disease outcomes and prognosis, CIGR, which is a multi-site NIH-funded research consortium, studied the molecular gene expression from esophageal biopsies of a very large number of patients, both pediatric and adult, with EoE. And by hierarchical clustering, they identified 3 distinct endotypes. These endotypes seem to describe 3 phenotypes: a benign phenotype with mild disease features, an inflammatory disease phenotype, and a narrow fibrostenotic phenotype. Again, suggesting that while disease duration or time of duration of inflammation and age may be important factors in terms of prognosis of patients with eosinophilic esophagitis, the distinct endotypes and phenotypes may also exist. Irrespective of phenotypes, and while we may one day have treatment algorithms that treat one endotype differently than another, for now we are left with having to help our patients select the best treatment for them. The key here is that treatment, whether it's medication or diet elimination, can be effective and can impact and improve prognosis. So here's an example of a patient that presented with an esophageal food infection. There's edema, linear furrows, hint of esophageal narrowing. And after treatment, the patient has a normal esophagus and resolution of symptoms. So again, treatment is effective. But adherence matters. Swallowed topical corticosteroids do reduce the risk for long-term bolus impactions in EoE treatment. This study demonstrates the occurrence of food bolus impaction during follow-up period in patients taking swallowed topical corticosteroid, and those taking it more often and more consistently, as seen on the right, in that time period were less likely to have an impaction. So while dose reduction could be considered in our patients once as they demonstrate therapeutic response, I propose that we inform families that continuing therapy has the greatest chance of reducing risk of impaction later to help them decide on the risk benefit for that child. In patients with severe esophageal narrowing treated with dilation, this work from Chicago also demonstrates the importance of medical or dietary treatment in obtaining histologic remission. Obtaining histologic remission, regardless of treatment strategy, predicted the ability to improve their esophageal diameter with the use of esophageal dilation. So briefly, just a word about dilation. In pediatric GI, I rarely have to convince others that treating inflammation is a major goal of treatment. However, I think one of the interesting areas to highlight, and one where I see considerable practice variability, is in the patient on therapy with persistent dysphagia. This is where I would like to highlight the role of endoscopic esophageal dilation in the management of EoE, as I sometimes see a reluctance to dilate in EoE, and whether this is a reluctance to dilate or a lack of recognition of esophageal narrowing is unclear. But the key here is that dilation can be used safely, but should be done with experienced providers. No dilation technique has been found to be more effective or safer in EoE. In general, a start low and go slow technique is recommended. For longer strictures or narrow caliber esophagus, I will tend to use a bougie style. And on the occasion where we identify a focal stricture, in that case, we'll use a through the scope balloon dilator. In this example of a young adult patient, this patient was identified to have a narrow esophagus and was dilated with a bougie dilator to 45 French. This resulted in a nice longitudinal mucosal rent. But this patient had improvement in symptoms in addition to using concomitant swallowed fluticasone. I did warn this patient about post-procedural chest pain and suggested that he not go out and eat chips and salsa that evening. But so severe esophageal stricture and the need for esophageal dilation is, of course, rare in our pediatric population. So we'll focus the rest of this time on therapeutic strategies. Goals of treatment in EoE include improvement in symptoms. We're in the business of making people feel better. We also want to reduce mucosal eosinophilia and prevent complications such as food impaction, esophageal stricture, and narrow caliber esophagus. We should admit, though, that eosinophils are an important, but albeit imperfect, primary endpoint in the evaluation and monitoring of EoE. So our treatment options include diet, drugs, and, as already mentioned, dilation. So dietary therapy includes elimination of presumed or identified food allergen triggers. And in its evolution, it started with the use of elemental diet and has included empiric and allergy testing directed elimination diets. Allergy testing directed diets, for the most part, have really not shown improved efficacy over empiric elimination diets. And while these diets have not been compared directly, they do appear to have relatively similar efficacy. Again, this slide summarizes the studies to date. And while we know these dietary eliminations can work, we need to recognize that the quality of evidence to support their use is actually quite low. And this information summarized here came from the technical review of management of EoE that was recently published last year. Therefore, the decision regarding which of the elimination diets to use is a discussion between you and your patients, because none of them can work if they're not being done correctly. I would also like to highlight the importance of using dietitians or other members of your team who can adequately educate your patients on how to do these dietary eliminations. As far as medications go, here in the US, we are still left without an FDA-approved medication for EoE, although we might be getting close. Corticosteroids have been the mainstay of EoE management and work. Here is an example of budesonide treatments and demonstrate improvement in eosinophils for high-power field at the end of treatment. There are 3 new steroid preparations on the horizon. As you guys are all well aware, we have been borrowing from the asthma world and doctoring these medications to be able to deliver them to the esophageal lumen rather than the lung. But again, there are 3 new steroid preparations that are being studied and are on the horizon that will be specifically formulated for use in eosinophilic esophagitis. And this includes a budesonide oral solution, a budesonide oral disposable tablet, as well as a fluticasone dissolvable tablet. And these preparations have recently completed either phase 3 or phase 2 clinical trials, 2 of which included adolescents in their study population. One specifically, looking at the budesonide suspension, in a study of 93 patients, budesonide suspension of 2 milligrams given twice daily improved symptoms, histology, and endoscopic appearance after 12 weeks compared to placebo. However, the percentage of patients that met histologic response, defined as less than 6 eosinophils per higher field, was lower than some other previously studied. This study also makes the point that maintaining therapeutic effect can be challenging. But 42% were able to maintain histologic response during a 24-week open-labeled extension trial. Which steroid do we choose? So Dr. Dellin in 2019 completed this double-blind, double-dummy, randomized control trial in 129 adults to compare the efficacy of budesonide to Flovent. And contrary to his hypothesis, the data actually showed no difference in peak eosinophil count, dysphagia symptoms, histologic response, or endoscopic improvement between the oral viscous budesonide and the fluticasone inhaler. And again, you can see these compared in panel A with respect to peak eosinophil counts, in panel B, dysphagia symptom questionnaire response, C, differences in histologic response, and EREFS score or endoscopic appearance in panel D. Again, additionally, there was no difference in adverse events between these two medications. So the point here, choose the one that your patient is going to take. Now, I'm not going to go too much into this because this can be a talk unto itself, but just as a reminder that PPIs or proton pump inhibitors are now considered a treatment for eosinophilic esophagitis rather than part of the diagnostic criteria. And we should keep in mind that the PPI response in EoE is common. 30 to 50% of EoE patients have histologic response to PPI. So given their relatively low cost and good safety profile, PPIs are a reasonable treatment option in a portion of our EoE patients. But we need to also keep in mind that there are patients who do not respond to available medications or dietary therapy. Swallowed corticosteroids and dietary therapy do not work in everyone. And there are also patients who have such severely restricted diets that quality of life and nutrition can be substantially impacted. And so for these patients, alternative strategies are needed. And biologic therapies are on the horizon. These biologic therapies often target eosinophil stimulation or function and have included anti-IL-13, IL-5, cyclic 8, and IgE have all been applied to the study of eosinophilic esophagitis. Early trials of these biologics were actually less impressive with regards to achieving primary endpoints. However, current ongoing studies are showing greater promise with significant reduction in organ eosinophilia and improved patient-reported outcomes. And so here are just a list of several of the biologics that have been studied in EoE, again, with variable achievement of primary endpoints. One example, though, that is encouraging is dupilumab. Dupilumab is an IL-4 receptor antagonist that targets both IL-4 and IL-13. Dupilumab has been already approved in the US for use in severe asthma and eczema. And with regards to EoE, phase 2 clinical trials are completed and a phase 3 trial is currently enrolling. In the phase 2 trial, 47 patients were randomized to study drug or placebo. 83% of those treated with study drug met the target of less than 15 eosinophils per high power field, and 65% met the target of even greater reduction of eosinophilia of less than 6 eosinophils per high power field. There was significant improvements in patient-reported symptoms, seen on the left, change in peak eosinophil count seen in the middle, and endoscopic appearance seen on the right. In looking at drug development, we also see that there are a multitude of different cytokines and areas for which to target. And so I will just mention briefly anti-cyclic 8 antibody. So anti-cyclic 8 antibody, or lirentelimab, is also in study in adults with eosinophilic esophagitis. And cyclic 8 is an eosinophil and mast cell membrane protein receptor, and its engagement by the antibody leads to apoptosis. So again, the results of this clinical trial are pending. So with regards to prognosis for our patients, EoE is a chronic condition. Without treatment, inflammation returns on average within 3 months, and this has been shown by several studies at this point. It does appear that most therapies continue to work if patients can maintain adherence. But there's a caveat that most of these long-term studies really have only been done for 1 to 2 years. So I'm going to propose that we really do need to monitor our patients with eosinophilic esophagitis. It's important because we are asking our patients to be on really daily treatment, whether that's taking medication or avoidance of foods. And it's a chronic condition. And again, because the long-term studies are limited to 1 to 2 years, monitoring is an important part of disease management. It's important in determining response to therapy. It's important in determining whether foods can be tolerated when they are being reintroduced. And it's also important to monitor in the concept of this being a chronic disease. We know that adherence can fall with chronic diseases. and that adherence to medication impacts outcome. And it's unknown what the duration of response will be really after 2 or more years. And because symptoms do not adequately reflect tissue inflammation, we do need to sample the esophageal lumen in some way to assess disease response at this point. So endoscopy is still the gold standard, but less invasive means of sampling the esophagus really would be ideal. So towards this, T&E has been used at our institution. At our center, so T&E admittedly is still invasive, but doesn't require anesthesia. And at our center, video goggles are often used for distraction. This picture is of a brave young lady who does this rather frequently for her food introductions. The scope, in this case, a pediatric bronchoscope, is introduced through the nares and the esophagus is intubated, at which point biopsies can be obtained. And through studies, we've seen that this is well tolerated with very low rates of adverse events. And while we're using smaller biopsy forceps, we have studied and looked to see that the tissue that we obtain is adequate for histology. Here's just a picture of the visual findings that we do see on transnasal endoscopy. So on the left is a relatively normal appearing esophagus. In the middle, we can start to see some evidence for linear furrows, pallor or edema or loss of the vascular markings. And the right, we can see significant and substantial white plaques. An even more or even less invasive strategy is the use of the esophageal string test. So in this, the string test takes advantage of swallowing a gelatin capsule. In the capsule is a weighted nylon string. It's swallowed and then the capsule opens up and the string releases. We tape it to the outside of the face and it's left in place for 1 hour and then removed. The esophageal portion is then analyzed for the presence of eotaxin 3 and eosinophil major basic protein 1, both eosinophil associated proteins. And in a study that included 134 children and adults, the EST captured these eosinophil-associated biomarkers and correlated significantly with peak eosinophils per high power field. Using combined eotaxin 3 and major basic protein 1 concentration, an EoE score is then calculated that can distinguish subjects with active EoE from inactive EoE or the normal esophagus. And combined, these two biomarkers have a sensitivity of 77% to distinguish between active and inactive EoE, and 69% to distinguish between active EoE from inactive and controls combined. Children and parents, as well as adult patients, as you can imagine, had a strong preference for the EST over traditional endoscopy. So less invasive means of monitoring our patients are on the horizon and becoming available. So in closing, I want to leave you with that fibrostenosis occurs in many, but possibly not all patients with eosinophilic esophagitis, and that distinct endotypes may exist. Diet elimination and corticosteroids do remain the mainstay of treatment options, but biologics are on the horizon to help treat some of our more severe and disease treatment-resistant patients. It's important to monitor your patients for treatment response. And the most effective treatment is the one your patient will do. So the most important part of choosing a treatment strategy for your patients is to engage your patient and family in shared decision-making. And so with that, I'd like to thank you all. This is our eosinophilic GI disease team on the left, and a picture of our hospital in the spring and summertime here in Denver, Colorado. And with that, I would like to take any questions and answers.
Muy bien, muchísimas gracias a la doctora Calies Menard-Katcher. Doctora Calies, ¿está con nosotros? Are you there with us? Are you here with us?
Yes. Sí. Gracias.
Gracias, gracias. Muchas gracias por la conferencia. Bueno, ya tenemos un par de preguntas en el chat, pero mientras tanto vamos a ir revisando un poco algunas de las inquietudes más frecuentes que se generan cuando uno discute este tema en cualquier escenario y frente a cualquier audiencia. Dr. Calies, in LASPGHAN, I've been coordinating for the last 6 to 8 years a working group about eosinophilic esophagitis. And there are certain questions that always arise every time we deal with the subject, every time we talk about eosinophilic esophagitis in any scenario in Latin America. There are always certain questions that arise that are always there, like in the back of the head of everyone. One of the most frequent questions I receive is what to do about the asymptomatic patient. Que hay una de las primeras interrogantes que uno podría hacerse con respecto a esofagitis eosinofílica es qué sucede con los pacientes asintomáticos. Muchos reportan hallazgos endoscópicos que aparecen de manera casual al momento de la realización de cualquier procedimiento endoscópico y que sugieren el diagnóstico de la enfermedad, pero un paciente que no tiene una historia clínica sugestiva. Entonces, what do you think about treating asymptomatic patients with casual endoscopic findings very suggestive of the disease?
Yes, so this comes up for us too all the time. So, and that's why I put that initial slide, because it's a chronic condition. EoE, so the disease, rather than just the histologic finding of esophageal eosinophilia, is a chronic condition that should have both esophageal symptoms as well as inflammation. Now, I think one point that I would make is the importance of asking multi-layered questions about symptoms. Often children have, there's the young child who presents with vomiting, bad abdominal pain, but there's the kind of school-age child that may have been developing inflammation and remodeling over the course of years, and they are more of this traditional phenotype that complains about difficulty swallowing. And they have evolved and grown up not knowing that subtle symptoms may be abnormal until they develop the food infection. Parents sometimes are even surprised when children report their symptoms around eating. So it's helpful to ask questions and to not just about abdominal pain or things of this nature, or say, have you ever had food stuck or do you have difficulty swallowing? Because they may not perceive it as difficulty swallowing. So asking questions about, are you a slow eater? I don't know about Latin America, but in the US, kids are given maybe 15 minutes to eat lunch. So sometimes, do you have enough time to eat your meal? Are they the slowest eater at the table? Do they wash food down often? Do they use a lot of ketchup or salsa or other things to make their food easier to swallow? Because oftentimes what we'll find is that kids really have more symptoms than even the parent may be aware of. So that's one. But the truly asymptomatic patient, I think they do come up. And what I'll do is have honest conversations with families and say, your child has this kind of inflammation. If left untreated, if this is chronic and is left untreated, they have a risk of developing more difficulty swallowing and food infection. And sometimes families opt to not treat, and that is their choice. And what I like to do is make sure that they come back and have annual follow-ups with me so that I can continue to screen that child for patients, and I give them a lot of counseling about what to look for in the home.
Thank you very much. Si pudiera resumir la respuesta de la doctora, tiene que ver con algo muy importante, que es la detección de la disfagia, digamos, en los momentos más precoces de la enfermedad. Un síntoma que a veces puede parecer muy obvio, pero que muchas veces no lo es. Hay niños que simplemente tienen una disfagia, digamos, subclínica, muy sutil, y que muchas veces pasa desapercibida por los padres y que se manifiesta como, por ejemplo, una lentitud extrema al comer, la necesidad de siempre tener un vaso de agua al momento de ingerir los sólidos para ayudar a la dilución de los mismos. Pueden ser signos muy sutiles de disfagia precoz que a veces pueden pasar desapercibidos en el paciente que pareciera, entre comillas, estar asintomático, pero que realmente no lo está, porque tiene esos síntomas sutiles que nosotros debemos interrogar y que nosotros debemos investigar. La segunda parte de la respuesta de la doctora tiene que ver con si realmente el paciente está asintomático y uno hace el diagnóstico de la enfermedad en un escenario en donde el paciente realmente está asintomático, el planteamiento es discutir la enfermedad y la progresión de la enfermedad con los padres para, junto con los padres, decidir sobre un eventual tratamiento en un paciente que, repito, podría estar realmente asintomático. Entonces, de alguna forma, involucrar a los padres en la decisión de si tratar o no y explicarles a ellos los riesgos, los beneficios y los riesgos de dejar una enfermedad como esta a su libre evolución sin tratamiento. Thank you very much. Okay, I'm going to read. You have access to the chat, so maybe you can read with me. There's a first question that is related to the ultimate endpoint or the ultimate goal of the treatment regarding eosinophilic esophagitis. In terms of eosinophilic count, what do you consider absolute remission, histologically speaking? ¿Qué se consideraría una remisión histológica absoluta desde el punto de vista de lo que es el conteo de eosinófilos?
Yeah, that's a great question that we are still working on. I love it when it's normal. I'm happy and satisfied if it's less than 15. Our FDA is starting to look at different cutoffs of less than 6. There is starting, in our own work, looking at our EndoFlip, we are starting to see that deeper remission may impact outcomes. But again, I think that this needs to be balanced with potential for side effects of medication, quality of life issues with continued dietary restrictions. So for right now, I would say the goal is less than 15. If you can get complete normalization, well, then that's fantastic. And there's starting to be some looking at less than 6, but again, less than 15, I'm very happy with.
Perfecto. La doctora acaba de expresar algo que sucede mucho en la práctica. No hay un número específico que nosotros podríamos decir por debajo de este número o por debajo de este número de eosinófilos por campo de alto poder tenemos una remisión absoluta o una remisión profunda. El concepto de remisión profunda tiene que ver con remisión sintomática, remisión endoscópica y remisión histológica. Entonces, bueno, el planteamiento que ella hace es muy lógico. Por debajo de 15 estamos bien. Idealmente sería que desaparecieran todos los eosinófilos de la mucosa o de las muestras de mucosa, pero tal vez la separación total y absoluta no se consigue siempre, pero si estás por debajo, si logras con el tratamiento que la cuenta disminuya por debajo de 15 y tal vez de manera ideal por debajo de 6, que es ahora otro punto de corte, podrías estar hablando de una buena respuesta. Que por debajo de 15 y preferiblemente por debajo de 6. Vamos a hablar del uso de los esteroides tópicos. Hay alguien que pregunta sobre la posibilidad de usar fluticasona cuando no está disponible la budesonida, lo cual es una opción válida. If you see question number 2, it's about the use of fluticasone when there's a scenario where budesonide is not available. What do you think about the use of fluticasone, which I believe is completely valid? ¿Y por cuánto tiempo, for how long do you use it and what dose?
Yeah, so one just additional point about to the last question about goal of histology, and I think that this was touched on, but just to really hit home that eosinophil density is not the whole picture. So what does their esophagus look like on endoscopy and how does the patient feel are also really important endpoints to consider in that definition of treatment success.
Yes, yes.
With regards to other swallowed topical corticosteroids, I use fluticasone quite frequently, especially in my older patients that may have lots of activities or out and about. I think there's an ease to use of that. We've also had luck with other types of inhalers, such as C-clesinide, for the treatment of eosinophilic esophagitis. And so in general, I would equate kind of Flovent 220, 2 puffs twice a day to be the equivalent of 1 to 2 milligrams twice a day of budesonide. 44 would be consistent with 0.5 milligrams budesonide, and so forth. And in terms of how long I use the medications for, I mean, I get to that point that this is a chronic condition. So we spend a lot of time in our clinic between nurses and medical assistants and physicians talking about adherence because the medications can't work if you don't use them, and we know the inflammation comes back if you stop. So we really use these medications chronically for years.
Okay. Let me go back to the chat. Okay. Before I go on with the chat, there's another big question that always surges in these discussions about this disease in the Latin American scenario, and is how many endoscopies can one patient require through life? You know? And we're talking about pediatric patients.
Yeah.
We have settled. I mean, we understand there's a need for the first one. We understand there's a need for a second one that usually sets the tone about, respond to therapy. But there are some that still sustain that there is a necessity of successive and several endoscopy, because we understand that there's not a really good correspondence between the clinic with the symptoms and the behavior of the disease in terms of endoscopy and histology. So how do you manage long-term patients in terms of procedurals, in terms of numbers of procedures? Lo que estamos tratando de definir es algo que surge mucho en las discusiones sobre esofagito eosinofílico, sobre todo en Latinoamérica y sobre todo cuando hablamos de pacientes pediátricos, y es el tema de cuántas endoscopias es necesario hacerle a un paciente diagnosticado. O sea, sabemos que en la primera surge el diagnóstico, sabemos que debe haber siempre una segunda endoscopia de control que nos marca un poco el tono en cuanto al tema de la respuesta terapéutica. Pero, y luego, seguimos haciendo endoscopias, con qué frecuencia, cómo lo maneja el médico en relación a los padres. What do you think about in terms of procedural assessment of these patients?
No, it's a large issue, and it's really what has pushed our group to try to explore lesser invasive options, and is really what encouraged my colleague, Dr. Ferruta, to kind of explore this esophageal string test years ago, and transnasal endoscopy by my colleague, Dr. Friedlander. And it is a large issue in EoE. What I would say is that we don't really know how often we need to survey. So once as I have a patient who is well controlled, symptoms are better, scope looks good, histology is reasonably responsive, I will discuss, I like to see the patients back every year, and we will think about doing an endoscopy every kind of 1 to 3 years. I think of adolescence as a high risk time period when we know that adherence to medications falls no matter what disease process you might be talking about. And so I think that that's an important time to re-engage and rescope, particularly when we start to think about transitioning to college, transitioning to an adult GI provider. In our patients where we have difficulty controlling the inflammation, or we're doing a lot of food reintroductions, that is where we have conversations about the balance of minimizing endoscopy as much as possible, but we still do use it frequently. And so I think that that's why we really do need to continue to be proactive in thinking about lesser invasive means of sampling the esophagus or understanding what's going on.
Sí. Bueno, en efecto, nadie tiene un número exacto ni un concepto preciso de cada cuánto tiempo debe hacerse una endoscopia de control en estos niños, ¿no? Pero sabemos que la clínica no es 100% siempre correspondiente con la patología en sí misma, tanto desde el punto de vista endoscópico como desde el punto de vista histológico. O sea, no podemos confiar 100% en la sintomatología, porque algunos pacientes están asintomáticos, pero tienen todavía inflamación activa. De manera que hay que tratar de trabajar sobre formas menos invasivas, como lo que la doctora mostró en términos de endoscopia transnasal, etcétera, etcétera, para poder hacer seguimiento de estos pacientes sin tener que recurrir a las endoscopias sucesivas, que es algo que afecta mucho y atemoriza mucho a los padres. There's a question about the time for the use of PPI. Okay, you said about PPI. We use a lot of PPI in Latin America because it's very easy for us to obtain PPI, to prescribe PPI, and the response is great. I mean, I really mean it. It's for us, it's a really, really good strategy. Treatment strategy. Do you use it for how long, and how do you use it? Because there's something I always try to clarify with my colleagues, because we understand PPIs as anti-acid drugs, but in this case, we're talking about PPIs as anti-inflammatory drugs. Y hay algo que yo siempre insisto con los colegas con respecto al uso de los IVP, es que estamos hablando del uso de IVP como drogas antiinflamatorias, no como drogas antisecretorias. So with this in context, what do you think about PPI in the management of patients with EoE?
Yes, I mean, it's like you've read some slides from another talk of mine. So exactly that. So clearly, PPIs are excellent at turning off acid. They are very effective at doing that, particularly at high doses, and most people don't even need those high doses. But there is evidence both at this kind of cell model, so in vitro, and there's starting to be some in vivo work that has been done that really seems to imply that PPIs are having an anti-inflammatory effect on the esophagus in EoE. And it's really fascinating. And again, that's why it's a whole nother talk. But there's a lot of evidence building that it is really working by a different mechanism in these patients. So I think we struggle a bit in terms of who the right patient is for PPIs, because they're cheap, they're easy to take. Mm-hmm. People, I'm sure this is not just true of Americans, like to fix their problems by just taking a pill and make it easy. And there is decades of experience with the use of PPIs for reflux. However, there is mounting concern about the use of chronic PPIs in children and adults. And so I think that that's where the decision just needs to be balanced. The risks of PPI need to not be overblown, but they need to also be considered in contrast to what may be the risks of decades of swallowed topical corticosteroids. So they have a role. I use them frequently. And I certainly use them whenever I think that there is concomitant reflux disease in the primary treatment of EoE.
Perfecto. Está completamente reconocido el rol de los inhibidores de la bomba de protones en el tratamiento de la esofagititis eosinofílica. Sin embargo, hay una advertencia, y es muy interesante lo que la doctora expresa en términos del uso a largo plazo. Tenemos que discutir con los padres el tema de riesgo-beneficio del uso a largo plazo de los inhibidores de la bomba de protones, pero definitivamente tienen un rol en el manejo de la enfermedad. There's a question about something that here we have no experience at all, and we're talking about dupilumab. So this is a territory for us unexplored. So how long do you use dupilumab, and do you know about side effects?
So we don't, so the study is a 52-week study. It's a long study. For those are the clinical trials. We don't have much in the way of experience of dupilumab in the clinical setting for eosinophilic esophagitis, other than the clinical trials. The common side effects that were seen in the asthma trials are conjunctivitis and dry eye, some dry skin. The conjunctivitis, for reasons I can't explain, was not seen particularly in the EoE trials. There is a lot of questions that are left unanswered with these clinical trials in terms of what happens when you stop the medicine, how long can we use these medicines for? So we will be learning a lot, I think, in the next 5 or 10 years about these medications with EoE.
Perfect. Thank you very much. Hay otra pregunta acá que me lleva también a otro tema muy controversial y muy interesante, que es el tema de la terapia de mantenimiento. There's a question that you may read in the chat right now that leads me leads me to another very controversial issue I find a lot of times discussing this subject with my fellow colleagues in Latin America, and is related to maintenance treatment. We know it's a chronic disease. We know relapses are frequent. We know adherence is hard and it's difficult because we are only human. So what about maintenance treatment? Is it for everyone? Should we keep all our patients under maintenance treatment? Should we be selective of the patients for maintenance treatment? And what would be the criteria to select those patients for maintenance treatment?
So I advocate for continuing everyone on some degree of maintenance treatment. I do think that there's value in working with patients and families to find the lowest effective dose to keep them there. And I have had patients who have had side effects from medications, and so I will cycle them per se. I'll have them take the medications for 1 to 2 months and then kind of stop for a month and restart. But I don't advocate for that. I really advocate for maintenance treatment in everyone. My hope is that as we learn more about these endotypes, as we learn more about how to follow patients beyond just eosinophils high power field, but in terms of how does the endoscopy look? What is the distensibility of the esophagus? That we will move towards a more tailored approach where people may be categorized as having mild, moderate, or severe disease, and we'll be able to counsel them in terms of what is the risk that they have on developing a food impaction or a stricture if they stop treatment. But we're not quite there yet.
Muy bien, nuevamente con el tratamiento de mantenimiento es controversial. La doctora apoya la idea de que todos los pacientes diagnosticados con esofagititis sinúrica deberían recibir terapia de mantenimiento. Sin embargo, obviamente hay que tomar en cuenta algunos aspectos, tal vez hay que tomar en cuenta los diferentes endotipos, el riesgo de cada paciente que es diferente a desarrollar complicaciones en el largo plazo, pero como la doctora, muchas escuelas y mucha literatura apoya la idea de una terapia de mantenimiento, digamos, universal para todos los casos, porque repito, estamos hablando de una enfermedad crónica que tiende a hacer recaídas frecuentes y otra vez mantener una enfermedad de este tipo bajo control probablemente requerirá tratamiento de mantenimiento a largo plazo. There's a question about transnasal endoscopy. Do you use transnasal endoscopy for follow-up? And I think in your lecture you established that. The biopsies are easily collected and the size of the tissue is enough. I think you mentioned that on your show, but maybe you can say it again, please.
Yes, absolutely. So I don't do transnasal endoscopies. My two colleagues, Dr. Freelander and Dr. Nguyen, do all the transnasals for us. But yes, we have studied and worked with our pathologists. The biopsy pieces are adequate for esophageal sampling and monitoring of disease. And we have patients that much prefer transnasal, and we have patients that much prefer sedation. And so we use both in the monitoring of disease.
Perfecto. Yo creo que el tema de la endoscopia transnasal es un procedimiento mínimamente invasivo, no requiere sedación, puede hacerse en el escenario de un consultorio. Los otorrinolaringólogos tienen la posibilidad de practicarla y nosotros los gastroenterólogos creo que podemos aprender mucho de ellos, pero bueno, yo creo que depende de la disponibilidad de cada centro, ¿no? Depende de la disponibilidad de recursos. A ver, let's see, there's another question here from Dr. Florencia Verdi. What is your experience with patients with persistent but mild symptoms who have histological remission? What to look in those patients? So, estos son pacientes, la pregunta de la doctora Verdi se refiere a pacientes que permanecen sintomáticos aunque histológicamente y endoscópicamente están mejor. ¿Qué pensar en esos casos? What to look in those patients?
It's a great question, and I think is more common than we would like to admit. So if the symptom is dysphagia, then I will get an esophagram with that dissolvable barium contrast pill, if possible. I use that as a functional test of the esophagus. And if it gets held up, I will offer that patient dilation. If the symptom is predominantly pain and there's no evidence for inflammation, we'll consider the use of an antacid medication, and also consider the fact that these patients may develop functional heartburn or hypersensitive esophagus as a result, possibly, of their primary esophageal inflammation. And so in that case, we'll direct treatments towards there using SSRIs, for example.
Perfect. There's another issue that, you know, in Latin America, we have studied the prevalence of the disease, and we have identified certain countries that behave like clusters of the disease. For example, we have Colombia and Brazil are very, very interesting territories in terms of high prevalence. Comparing to countries like Mexico, for example, despite the large population of a country like Mexico, it's amazing how the disease has a very low prevalence for reasons we don't clearly understand yet. But those countries where the disease is highly prevalent deal with the same degree of frustration because it's a chronic disease. What to do with the patients that relapse once and over again? What to do with the patients that are non-responsive? You know, they're not responsive to diet and steroids. And those patients are there. They're still, you know, knocking our doors all the time. Patients that are refractory patients. What do you do, and how do you strategize those cases, the management of those cases?
I think, again, it depends on what the predominant symptom is. So if it's dysphagia, then if we've tried our hardest and we cannot treat the inflammation, they may deserve a trial of dilation to see if that helps their swallowing function and their symptom. If it's pain, then we need to talk about how to address the pain symptoms. So whether that's use of, I think there is overlap between, or their patients can have concomitant illness, so they can have functional GI disease and EoE at the same time. So I think that's just really important in terms of like, and you guys know this, right? Like the history in getting out, what is the thing that you can kind of help them move forward with? We may not be able to fix all of their symptoms in one clinic visit, but what's the symptom that's most important to them to help and to target that if our treatments for EoE specifically are not being effective.
Muy bien, estamos hablando de los pacientes refractarios, los pacientes que no mejoran, los pacientes que persisten sintomáticos a pesar de todas nuestras estrategias terapéuticas, a pesar de la dieta, a pesar de los esteroides, pacientes que persisten sintomáticos y que se encuentran muy a menudo y muy frecuentemente, sobre todo en países con prevalencias muy interesantes de la enfermedad, como por ejemplo Brasil y Colombia. Y la respuesta es que, bueno, todo depende del diagnóstico, el síntoma predominante, ¿no? Si el síntoma predominante es disfagia, si hay una disfagia persistente en un paciente bien manejado, bien diagnosticado, tal vez esa disfagia persistente amerita un abordaje endoscópico con dilatación, porque es la forma de enfrentar un síntoma persistente a pesar de un tratamiento médico. Bueno, vamos a hacer ahora el abordaje endoscópico. Y bueno, pues un poco la idea es tratar otra cosa muy importante en el paciente sintomáticamente persistente, es que hay que recordar cómo pueden, digamos, superponerse síntomas funcionales. La patología funcional también puede estar presente en pacientes con esofagito eosinofílica. Y muchas veces hay una pirosis persistente que es de carácter funcional. Entonces, hay que estar pendiente con el tema del el componente funcional en el escenario de una enfermedad crónica y de una enfermedad orgánica. Las dos cosas pueden estar superpuestas. Hay una pregunta en relación al uso de los inhibidores de la bomba de protones. Do you think there is, or that we should prefer certain PPI, a certain molecule over the others? Or do you think they are all effective and all good enough for all patients?
I think they can all be effective. Unfortunately, here we're often dictated by what their insurance might cover and what is most cost effective for them. I tend to just choose what is the most affordable for the family. They've not been studied head to head, and I think they can all be effective.
What's the maximum dosage do you prescribe in a patient with EoE? La dosis máxima de cualquiera de los inhibidores de la bomba de protones, ¿cuál podría ser?
Yeah, great question. So I think it depends. If I'm using it to see whether PPI can be effective, I will use maximum 20 milligrams omeprazole twice a day equivalent. Because what I want to know is whether this treatment can work for them long term. And so I want a dose that I feel comfortable keeping them on long term. If I have a patient who is very symptomatic, might I go a little bit higher? Sometimes, but short term, and really, even the rapid metabolizers, that dose should work. Occasionally, I have switched them to esomeprazole in case they are, one of these more kind of rapid metabolizers that may have increased benefit from that preparation.
Perfecto. Espero que haya quedado claro el tema de la dosis. Hay un comentario del doctor Benjamin Gold que tiene que ver con la evidencia que hay en relación al efecto antiinflamatorio que tienen los inhibidores de la bomba de protones. There's a comment from Benjamin Gold regarding the anti-inflammatory effects of PPI, and there's a real evidence in vitro studies that show that PPIs have indeed an inflammatory effect, which explains its beneficial effect in these patients. No? So I think
yes.
We all agree with that. Okay, in terms of diet treatment or dietetic treatment, do you use it together with PPI or steroids, or is it better to use it alone, every one of them? This is a very interesting question also, because I always tell my colleagues, don't burn the candle by both ends of them. Don't try to, I think the word in English is not coming to me, but don't try to, overuse everything you have in hand. Try to be escalonated. What do you think between the escalonating approach, or let's do it all together the hard way, try to control the symptom the fastest way we can? What do you think?
I prefer what you are implying, which is that start with one treatment, choose one, choose PPI or choose swallow topical steroid or choose diet, and commit to it and see if it works. I think it becomes more challenging when you have a patient who's on all three treatments to piece apart which is the one that is working. And ideally, we want our treatments to not be worse than the disease itself. And so choosing kind of the least the least amount of therapy that can be effective in the patient. So I admit that this approach is very time consuming, but that is why having family buy-in and understanding why they're doing the things they're doing and choosing what approach may be more effective and more feasible for them as a family is important. So that said, we of course see patients that need multiple layers of therapy and are on swallow topical steroids and diet, and may also be on PPI. But ideally, for the vast majority of our patients, I like to choose one treatment approach first.
Muy bien, sí, el tema de abordar al paciente desde un punto de vista terapéutico con todas nuestras herramientas o ir trabajando de manera escalonada. Ella comenta que hay pacientes que realmente necesitan tal vez un abordaje más agresivo, que necesitan dieta, necesitan esteroides, necesitan IVP todo al mismo tiempo para poder controlar una enfermedad severa, pero en la mayor parte de los casos tal vez un abordaje escalonado sea lo más razonable. Y cuando hablamos de un abordaje escalonado significa que tú puedes comenzar trabajando con dieta, evaluar respuesta clínica, endoscópica, histológica de la dieta, y si no funciona la dieta, luego puedes tal vez escalonar o digamos pasar a otro nivel en donde puedes utilizar una droga, acuérdense de las 3D, dietas, drogas y dilatación, y dentro de esas drogas puedes utilizar IBP o puedes utilizar esteroides, y así sucesivamente puedes ir tratando de evaluar a qué responde mejor tu paciente. Yo creo que one of the things that this disease is telling us and is showing us and is teaching us is the concept of that not every patient is the same, and we need to understand that the personalized behavior of the disease is very important. I have patients that respond really in countries where the prevalence is low. Patients just with a mild diet and a small dose of PPI will respond beautifully, and they will be, they will have excellent behavior mid and long term. But when you're talking about the hardcore disease, those patients, you need to understand that some of them will require a certain approach and some others will require a different approach. There's not as doctors, we usually tend to prefer the recipe that solves everything. But in this particular case, that recipe doesn't exist. We need to be very, very, very smart to understand that some patients will require something and will do better with something than others, and keep that in mind always. Yo estoy haciendo una reflexión porque como médicos siempre nos gusta tal vez la receta médica que todo lo resuelve. Este es el tratamiento, reciba este tratamiento por un número determinado de semanas, a una dosis determinada, y esto va a resolver o controlar su enfermedad. Y la esofagitis eosinofílica es una enfermedad que nos ha enseñado que esas recetas universales no funcionan, porque algunos pacientes van a responder muy bien a ciertas estrategias y otros tal vez no, van a requerir una estrategia completamente diferente. Y yo creo que la práctica clínica nos va a ir diciendo, nos va a ir enseñando cómo abordar cada caso desde el punto de vista personal. Dr. Calies, your last comments before we wrap it up tonight.
Oh, this has been an absolute pleasure. I really enjoy the Q&A sessions because I learn so much about what's important to other providers. And that really motivates me in the care and thinking about research and what are the next questions that need to be asked. So thank you for your questions and your time. This is an absolute joy. I hope one day to actually soon we'll be able to travel and I may actually be able to visit some of you in your countries. But I really appreciate being able to take advantage of this kind of newfound Zoom webinar world that has really expanded because of the pandemic and to chat with you guys this evening. So thank you. Thank you guys so much for the invitation to talk with you. And I've learned a lot and really enjoyed it.
Thank you very much for your presence, for your knowledge, your experience. You're willing to share that with us. I think in Latin America, EoE, like IBD, is coming strong. The more we know, the more we are aware of this disease, the more we are aware of the symptoms that may elicit a thought about the possibility of a diagnosis. The more we train in terms of what the disease is and how it behaves, we'll have more patients to treat, and we'll have more patients to deal with, and we'll need more knowledge and more evidence and more experience, and that's what this is all about. So thank you very much. Muchísimas gracias a todos los que se conectaron, a los que preguntaron, a los que intervinieron. Gracias a la doctora Calies por su participación. Y bueno, buenas noches y nos veremos en una próxima oportunidad. Muchísimas gracias a todos. Gracias a Carlos Timosi, como siempre, por su orientación y su apoyo tecnológico. Thank you, Ben. Thank you, Carlos, Dr. Calies. Thank you and good night.